Hi, it's Dr. Baker Townsend, and I want to talk to you about nursing care of the high-risk newborn. We've talked a little bit about things that can happen during a traumatic delivery, but we're going to look at some more factors in this process. So high-risk infants are classified according to the following factors: birth weight. Remember, we are always concerned about low birth weight or very high birth weight babies. Gestational age, less than 37 weeks, we are very concerned about preterm deliveries. And then after 40 weeks, we worry about postdates, and we worry about placental damage and asphyxia in utero due to placental damage. And then, of course, if there's any predominant pathophys, we definitely are worried about that. So most of the high-risk infants are high risk simply because they were born too early. The earlier they are born, obviously, the more risk factors they have. We worry about preterm babies that are even 37 weeks in regard to respiratory distress. And of course, the earlier they are, the more we worry. They develop a suck response around 32 weeks. So babies who are in this kind of range who haven't really developed a suck response, we worry about blood sugar on them, because we have to usually put down an OG tube, oral gastric tube, in order to feed them because they don't have a suck response. Organ systems that are immature, obviously, liver, problems like that. And then preterm babies weighing less than 2,000 grams are different than a term or post-term baby at the same weight. We just kind of talked about that. Preterm babies have a lot more risk factors than do just low birth weight babies who are term. Extremely low birth weight babies are babies less than 1,000 grams. And so a lot of times we worry about how old they are, actually. So we really know that we can save babies that are 24 weeks and greater, but they do have a huge risk of having problems later on. So when we decide to resuscitate a baby that's less than 1,000 grams, you always have to talk with the family and make sure before the resuscitation starts to what extent do they want to continue it. It's exactly like a DNR. So you have to say, after 3 minutes, or, what type of interventions. Who should decide? That's a frank conversation that the provider needs to have with the parents. Is the cost of the resuscitation justified? This is a very difficult one, whereas if there's a baby that we don't know the gestational age, a mom delivers, and the baby cannot survive, say the baby's less than 23 weeks old, and then we use all the cost and put the baby through trauma to resuscitate the baby when in fact the baby doesn't even have a chance. So is the cost justified? And do the benefits of technology outweigh the burdens in relationship to quality of life? We're very quick to use the technology we have. A lot of times, though, our society is very slow to think about the quality of life that the baby will have after these interventions. So all of this must be weighed. So physiologic functions, of course, respiratory is the last one to mature, and we really worry about that one. Cardiovascular function, we know that we can have some problems with the cardiac system, and we can even have problems with the cardiac system related to the respiratory system. Maintaining a body temperature, neutral thermal environment. That just means the baby's not too hot and not too cold, and so we don't want the baby to have any cold stress whatsoever. And then central nervous system function. We remember with preterm babies, they can have really friable veins in their head, and so they're at high risk for a hemorrhage or a brain bleed. So we worry about that. Of course, we want them to have adequate nutrition. We want moms to pump, and we can take the breast milk and give it to the baby via OG tube or NG tube. Well, it's OG tube, it's not an NG tube. Maintain renal function. watch their urine, make sure they're urinating, maintain their blood counts, make sure their blood counts are okay and they're not having any issues, and then resisting infection. That's really one of the bigger problems we have in the neonatal nursery is infection, and it's mainly because of poor hygiene practices, hand hygiene. Most of our nursery nurses are very good to protect their babies from contamination. However, we know that healthcare workers come in and out of environments and bring in infectious processes, and these babies only have passive resistance from mom. So breastfeeding or taking breast milk is a major help for babies in the NICU. So growth and development potential, it's very difficult to predict for a preemie what's going to happen, but we definitely try to anticipate that there's going to be some type of delay. Corrected age, so how you correct the age of the preemie, you add the gestational age and the postnatal age. So you just add the two together and that will give you the corrected age. Of course, we want them to catch up by the time they're 2.5. By the time they're 2.5, we would like for them to be on track. And then very low birth weight survivors have a 15 to 25% chance of neurologic or cognitive disabilities, which is, you know, sometimes they have cerebral palsy, sometimes they have residual problems from a brain bleed. But if these statistics are actually very good regard to very low birth weight babies. So that's a positive thing. Care and management, of course, I've talked this to death about maintaining body temperature. You just really need to keep them warm so that we don't have any type of heat loss from conduction, convection, evaporation, or radiation. Of course, rapid changes in body temperature can cause apnea, so we don't want them to get cooled off and go into respiratory distress and then have an apneic episode. Respiratory care, so neonatal resuscitation, so we can bag the baby, meaning give the baby oxygen with a bag, give the baby oxygen, blow by. We can put the baby under a hood. We can give the baby nasal cannula. We can give the baby CPAP, or continuous positive airway pressure. That's prior to putting them on a ventilator. This just kind of pushes the air in. Sometimes they're resistant. Mechanical ventilation, then high frequency ventilation. So yeah, this is from lowest resuscitation to highest that we would have. And here's a CPAP. Here's an OG tube. Here's an OG tube. And they're putting it down, and we can just give the baby a little, this is actually an NG tube. Here's an OG tube. But we can give the baby formula if the baby suck has not responded. Of course, the very first thing that you want to do after you get your tube installed is to have radiology come and verify placement is in the correct place. We always want to make sure that we verify it's in the stomach prior to feeding the baby with a diagnostic tool so that we do not accidentally introduce any formula into the airway. So we can, so if their baby is very early, we can give them surfactant, and that's called NeoSurf or InfaSurf. S-U-R-F is the last little bits of the word, and it will help them. We just spray it down the ET tube, and that can help them to start developing surfactant. Additional therapies, nitric oxide, ECMO, extracorporeal membrane oxygenation. ECMO is a very serious heart-lung bypass. And babies will stay on this until we can get whatever corrected. A lot of time it's meconium aspiration, or they have some type of major problem. It's super expensive. We only have ECMO at a couple of hospitals, UF Health downtown and at Baptist, because these are very high-risk places. Partial liquid ventilation. This is just delivering oxygen in a liquid form, and that's still it's not used very much. It's still experimental. And then, of course, we need to wean the baby from a respiratory device before they go home. So nutritional care, we want to make sure they continue to gain. They're not breathing too fast and losing water. Elimination patterns. These are very different than your normal term baby. So we just want to make sure that their eyes and nose are balancing. Oral feedings is optimal, but a lot of times we have to have gavage feedings. because they do not have a suck. Sometimes they have to have a G-tube in very small infants, or if we have a problem with the upper head or neck in the baby, we can't put down an OG tube. TPN, sometimes we have to have advanced feeding and non-nutritive sucking for comfort. We can see this guy's in an oxy hood. He's got his IV therapy here. He's got his passy here to help develop his suck. He also has a UVC, an umbilical vein catheter going in here, so there's some access. So he's got 2 access sites. Skin care, their skin is so very thin and friable, so we want to always make sure that we assess their skin every day. We don't want to use soaps. And environmental concerns, we try to keep, well, just remember that their brain is still developing. They should not be out of utero. They should be having very little sound as if they were in the uterus, and light. And so, you guys, we want to keep the NICU as quiet as possible. That's why it's in the light as dark as possible, to mimic the uterine environment that they should be in to help stabilize them until they're born. So you guys, we keep it very dark, we keep it very quiet, we try to keep it very, very clean. Positioning, we always are, we want to change their positions just like we would with anyone else. Reduce any stimuli. We don't want any loud talking. Again, we don't like beeping from the machines. We try to keep those quiet. Infant communications, touching with their mom, infant stimulation, kangaroo care, just skin to skin with the baby. Really important for the baby's development. Parental adaptation, so it's very, very hard for parents. So they have a baby thinking they're going to take this baby home, and now the baby's in the NICU, so it's very, very difficult. Mom also has a big dramatic decrease in her estrogen, so she has postpartum blues that can turn into postpartum depression. It's very difficult financially on the whole family, emotionally on the whole family. So you really have to give a lot of support. Just listen to them, and try to get them to interact with the baby. Respiratory distress syndrome, when we talk about this a lot, this is usually from preterm babies, or this can be post-date babies who or babies of diabetic moms who just did not get enough surfactant because of the high sugar levels. It can also be babies who have meconium aspiration syndrome, and they could aspirate the plug and they could have respiratory distress. So if you give them high levels of oxygen, it can cause changes in their eyes. It can cause some blindness, retinopathy of prematurity. We found that out a long time ago, so we don't give them high levels of oxygen any longer, but it can be associated with too much oxygen. BPD, bronchopulmonary dysplasia, and we see this very often in premature babies. So they have dysplasia of the actual epithelium, but the only good thing is as they age and their lungs grow, they usually grow out of this condition. Most all preterm babies that are 24 weeks to around 34 weeks, they have some degree of BPD. And then patent ductus arteriosus, that's because we did not have that change in the prostaglandins, so a lot of times they have a patent PDA, so sometimes it has to be corrected surgically, sometimes they can give them medications for this, indomethacin. This is when they're just bagging a baby. They're trying to give this baby some oxygen. This baby's having a hard time. That looks like this baby had meconium staining. You can see how this cord is brown, and it looks like meconium all over the baby. So this baby may have aspirated some meconium or the plug. Okay, so here's some more problems that we can have with premature babies, especially if they've had some respiratory distress. The first one, and the germinal matrix hemorrhage is very often happens to premature babies. They have very thin, friable vessels in their brain, and if they have respiratory distress, it can damage the hilum membrane disease. It can damage the actual brain. So you can see it occurs in infants less than 34 weeks. If they have a history of hypoxia or birth asphyxia. Also, you guys, this can happen in utero. But I have these cross sections that I want to show you the degrees of how bad this can be for Interventricular hemorrhages of the brain. Here's a grade 1. You can see there's some bleed here. Grade 2, and it's greater. This is just like a stroke for a baby, like a hemorrhagic stroke. Here's grade 3, and then here's grade 4. Really sad. These are responsible for morbidity and mortality in the newborn. Cerebral palsy comes from this, especially the grade 3s and grade 4s, and it can create all kinds of learning delays and problems, even for these very small grade 1 and 2s. Necrotizing enterocolitis. So a lot of times, you guys, if there's ischemia to the gut, if there is not enough oxygen going to the gut can die. Then bacteria in the gut. So now you have decreased oxygen going to the gut for function, and you have bacteria growing. So that's called necrotizing enterocolitis. Bacterial colonization, ischemia, we talked about that. And then when we have enteral feedings, and we can introduce bacteria there. So you can see there's an inflamed bowel, inflammation of the mucosa, and you can see the actual infectious process here. So you guys, this baby a lot of times will start bleeding in his or her gut, and the hemoglobin is going to go down, and the gut is going to get really, really big because there's so much inflammation of the gut. So when you're in the NICU, you will see them talking about belly measurements, because we're so afraid of neck in the NICU. Neck can very quickly kill a neonate, so we're very worried about it. And sometimes they have to have a colectomy. They have to have a partial removal of the colon, of the part that's really ischemic and bacteria laden, so the baby doesn't get septic and die. So you guys, this is just two big things that can happen that we worry so much about. Complications, pain response. Babies have pain. They have pain memory, and so you guys, we treat them just like we would treat anybody else. We want to give them things for pain. They give them morphine. They give them sweeties or sucrose to help. So you guys, we definitely do not want our babies to be in pain. Late preterm infants, this is the babies that are born anywhere from 35 to 36. They have all these problems. Respiratory distress, they're on that verge of getting enough surfactant. They can have thermoregulation problems because not enough brown fat. Nutritional problems, they may have a delayed suck, hypoglycemia, hyperbilirubinemia, and infection. Post-mature infants, we worry about them because we know that they have had some hypoxia in utero. When they have the hypoxia in utero, they could have meconium, and so this can cause major problems. Obviously, if we aspirate the plug into the actual main bronchus, the baby may not be able to breathe. And then they can get persistent pulmonary hypertension of the newborn if we're having any type of respiratory issues. Other problems, small for gestational age or IUGR, intrauterine growth restriction. It could be from problems with the placenta. We can have prenatal asphyxia, hypoglycemia, hyperglycemia, polycythemia, which we talked about last week. When there's not enough oxygen or not enough food being delivered to the baby will make more cells. We'll have too many red blood cells, and then that sets the baby up for a clot or very high bilirubin levels. And then, of course, heat loss, we worry about them. Large for gestational age, we've talked about this a lot, greater than 4,000 grams. So LGA, despite the gestational age, is when you chart the baby out and you do a Ballard score and you see that the baby is greater than 90%, and then greater than the 90th percentile, we know this baby is large, so we worry about it. Of course, you can have an LGA preterm baby or postterm baby, and then of course the biggest ones are the babies, infants at risk, infants of diabetic mothers. Discharge planning. A lot goes into the discharge planning. A ton goes into the discharge planning. Home care are assessed. The parents are assessed. They do go through major teaching information. They have referrals. Sometimes the people come with a billy blanket to their house. The apnea monitors. A lot of times nurses will come into the home and assist them. And so then we also make sure that they have all of their regular routine screening exams before they go home, their PKU and their hearing screen, and of course their hepatitis B vaccine if we can. So we do, sometimes you guys, if you're in an outlying hospital and you have to transport to a level 3 NICU, you know, the baby will be transported. It's very upsetting. Reasons that it's ideal for the maternal transfer to occur with the fetus in utero. You should try to always have the baby and the mom go together before the baby is born, excuse me. And we have less problems with the baby if the mom and the baby go, because then you can keep the baby in longer. Anticipatory grief, if we know there's going to be an impending death, or we know she's going to deliver less than 24 weeks, you know, we have to like kind of start talking about it with the parent to prepare them so that they can understand. Moms and dads who have babies with debilitating diseases, we have to really kind of set them up for what the baby's going to look like, the problems the baby may have, and how we can help the baby. Loss of an infant, so very difficult. Of course, you want to, you know, do the same things you would if the baby were alive. You would want to dry the baby off, wrap the baby up, do footprints, allow the patient to hold the baby, take as much time with the baby as they want, provide for privacy, answer any questions they may have about the baby. Sometimes they look at, you know, just all the different parts of the baby and they are scared that, you know, they did something, and you have to reassure them that you know, that, well, I mean, you would reassure them if they didn't do anything to hurt the baby. Preparing families for the inevitable death of a baby. So if you know the baby is 22 weeks and the baby comes out gasping, you have to let them know that, you know, the baby will eventually stop breathing. Some babies do go home on hospice and palliative care. This is especially true when you have a baby who's brain dead at birth, and sometimes they send the baby home and the baby does not get fed because there is no brain activity and no sucking reflex, and it would be the same as a G-tube or a PEG tube for a patient in hospice. So it's really hard when they're this age. I'm just going to go on to the next chapter, which we know a lot about. So acquired problems. So trauma during delivery is a big one. Infants of mothers with diabetes, neonatal infections, maternal substance abuse, and caffeine and antidepressants. We're going to talk about these. So birth trauma, you guys, is really difficult when there's a very rapid delivery. The baby can have skeletal injuries, can have head injuries. Then we know that can lead to bilirubin problems. We can have a shoulder dystocia where the shoulder gets stuck, and we can have all kinds of problems. So the risk factors for birth trauma: young and older mothers, first-time moms, uterine dysfunction. No matter if the uterus worked too hard, and work too fast, so that would be like a precipitous delivery, or it worked too long, whatever. Pre and post term. Preterm because the baby is so friable, the vessels are so friable, so in a preterm baby you can actually have injuries to the brain. And then post-term delivery, we have a big baby. Cephalopelvic disproportion, where the baby contracted against the pelvis and was never going to come out. Oligohydramnios, too much amniotic fluid. Usually that's in conjunction with gestational diabetes. Macrosomia, big babies greater than 4,000 grams. Multifetal gestations, and we kind of talked about that with head injuries with a vacuum. Abnormal and difficult presentations, and obstetric birth techniques. Soft tissue injuries, we can see all this bruising on this poor baby's head. This baby looks like it had its head out, and a shoulder dystocia, and the blood was cut off from coming back, so the whole baby's face bruised like this. What we do know is all this bruising, we have all these broken terminal capillaries, and the bilirubin is going to have to be broken down. So this baby, not only is this baby has facial bruising, which you feel very sorry for the baby, but we're going to have to monitor the bilirubin levels very closely. Erythema, ecchymosis, petechiae. You can see these little pinpoint petechiae on the baby. Edema, forceps. Of course, forceps can cause soft tissue injuries because we're going in blindly, and we can have some bruising right here on the side of the face. And accidental lacerations, especially with a C-section. Sometimes the surgeon goes a little bit too hard and the baby gets a laceration on the body. They can have subconjunctival hemorrhages or retinal hemorrhages from the pressure, caput, cephalohematoma, and subgaleal hemorrhages in the brain. Skeletal injuries, we know that they're very spongy. They have, their bones are not ossified, so we usually do not have fractures, but we can have linear skull fractures, clavicle injuries. That usually happens with a shoulder dystocia, and femoral injuries. This sometimes happens. A humerus or femoral fracture can happen when the baby has one leg hanging out and has one leg up in a breech position. And so sometimes you can have a baby with a fracture that way. You can see this is a clavicle fracture, and this was probably from a shoulder dystocia where the shoulders were stuck, the head came out, the shoulders were stuck. Now we have a brachial plexus injury to these nerves here that go down the arm, and so we can have some problems with the arm, and of course we want to make sure we stabilize that. We have brachial plexus damage, nerve injury, Herb Duchenne palsy, any of these, which makes it really hard with deliveries. Phrenic nerve injuries, and then we can have some palsy of the face, facial paralysis, and that can be from using the forceps. And I kind of think that's really what happened here. You can see there's some type of lesion on the face. Central nervous system injuries, intracranial hemorrhages, subdural hemorrhages. Of course, these look just like your regular patient with a brain hemorrhage. Subarachnoid can be in the trauma and can be from hypoxia. Then spinal cord injuries. We don't really see those a lot, but we can have spinal cord injuries with a myelomeningocele or a meningocele. They're just not very common. Pathophysiology of diabetic mothers we've talked about. We worry about big babies, and we worry about sugar, and we worry about hypoglycemia, and obviously you know that we worry about respiratory distress. You can see this is a big baby, and he can have skeletal problems coming out, plus the other three. Macrosomia, the shoulders get really big, leading to shoulder dystocia. Birth trauma and perinatal hypoxia is because the baby's head gets trapped and the carotids get compressed. So sadly, the baby can have decreased oxygen to his or her brain. And then respiratory distress syndrome, maternal hyperglycemia, can lead to fetal lung maturity problems. Hypoglycemia, our level is 45 in term infants. How do you know this baby has hypoglycemia? The baby's jittery, has apnea, tachypnea, and cyanosis. Remember, acrocyanosis is okay, just the hands and feet, but if the legs or essentially the baby becomes cyanotic, that's a problem. Hypocalcemia and hypomagnesemia is usually not present to 42 to 72 hours of birth, but sometimes we have to correct that as well because they all three go hand in hand. Cardiomyopathy, so we know that the higher the circulating blood sugars during the time of organogenesis, during the first 6 to 8 weeks of pregnancy, can cause problems with the heart. We can have hypertrophic heart, non-hypertrophic heart disease, so that's a huge problem. When the baby comes out, the baby may have polycythemia because of the excessive sugar. So you guys, that's going to cause hyperbilirubinemia. So, of course, we know all of our nursing interventions for bilirubin levels. Sepsis, we can have neonatal infections that can cause sepsis, really sad, hard. And their babies only have passive immunity, so it makes it very hard on them. Interventions, breastfeeding, of course, we're going to give them antibiotics. We don't want to introduce anything to them. So extreme hand washing before you touch the baby and after you touch the baby. Use standard precautions, and then antibiotic instillation into the eyes to prevent blindness from gonorrhea. Other transplacental infections that cross the placenta: toxoplasmosis, gonorrhea, syphilis, varicella zoster, chickenpox, and hepatitis B. This is secondary syphilis. You can see on the hands and the feet, and we know that syphilis has made a bad comeback, and it's terrible. And you can see this is some type of pox virus. Other torch infections: HIV and AIDS, rubella, cytomegalovirus, herpes, parvovirus, and enterovirus. And this is GBS, group beta strep, and we've talked about this a lot. We want the patient to be tested for group beta strep on outpatient if it's unknown if the mom is a carrier of the normal flora group beta strep. If we do not know the results, we're going to cover her. We are going to give her prophylaxis. We know that group beta strep is one of the leading causes of neonatal morbidity and mortality in the U.S. Other types of bacterial infections that can hurt the baby: E. coli, Staph aureus, listeriosis. The listeria one is a big one about telling patients not to eat unpasteurized cheese, hot dogs, things like that. Listeriosis can be a really bad one. And of course, chlamydial infections. Fungal infections, Candida albicans, thrush can cause diaper dermatitis, and they can get just, because it's moist and damp in the diaper, so they can have a lot of problems with that. And it can be communicated from the mom to the baby. Tobacco, substance abuse. We do not like for them to have tobacco. We know that they have elevated levels of nicotine, and we know we have a lot of damage to the placenta. So we know that it can harm their intellectual ability and development. Alcohol, we know fetal alcohol syndrome, so fetal alcohol spectrum disorders. Because it is a spectrum disorder, you can have, just a touch all the way to full-blown fetal alcohol syndrome. This is the stages of development and the teratogens, and we've already talked about this. Like the very early first trimester, you're going to have more problems. And then here's some teratogens that could cause major problems. But the earlier the introduction, even sugar, with cardiac abnormalities, any type of problem in this first trimester, we can have all these big issues. Later, we can see that it's usually just external genitals, weight, and behavioral problems. Tetracycline is a sample where they can change their teeth. So the earlier the introduction, the worse. Heroin is a huge problem right now, huge problem, because we've taken opioid access away from people, and so now they're turning to heroin. Heroin withdrawal was seen many times in babies, and that's called the neonatal abstinence syndrome. It's just like you would see with anybody else who was withdrawing from heroin. Methadone is a synthetic opioid or opiate, and they give moms methadone to get off of heroin. So there are a lot of babies born in America that are on methadone, but it's a little bit better than them being on heroin. It resembles heroin withdrawal, but it's methadone withdrawal resembles heroin withdrawal, but tends to be more severe and prolonged. It's just because it's synthetic. This methadone, however, is titrated down. So which we don't want to withdraw. We just want them to titrate very slowly off of it. Marijuana, we know that there can be short limb syndrome. We can have preterm labor with marijuana. Cocaine, of course, causes a big vasoconstriction and causes the placenta to tear off of the wall of the uterine lining. Methamphetamines, of course, anything that's, can cause a vasoconstriction, can cause placental abruption, preterm birth, IUGR. Ecstasy, we know that it can cause damage to cells containing serotonin, which is super sad because they will not have the same happiness and satisfaction that most people have that do not have damaged cells that contain serotonin. Here is the neonatal abstinence scoring system. I'm so sorry, that's my dog. And you have this copy on your test map, and the higher the score, the more withdrawal symptoms we are seeing. So our goal here is to give the baby morphine and slowly titrate the baby off so that these numbers will continue to decrease until we gently wean the baby off. It's very sad to see babies go through the NAS, neonatal abstinence syndrome, because they've just been addicted since they've, been created. So other drugs of concern, caffeine. We don't really want moms to take a lot of caffeine, and we know that babies can be addictive and have headaches. We worry about SSRIs. A lot of people are on SSRIs, and just like with any other drug for psychiatric conditions, we would always do a risk to benefit analysis to see if this mother should remain on an SSRI. So substance, we do assessment, education, social support, pharmacologic treatment, drug dependence. Breastfeeding is difficult, especially if it's marijuana. They do not want to let the mom breastfeed. But yes, there's a whole lot of debate on these issues as far as breastfeeding and drug addiction. So I encourage you to look that up on your own. And that's about it. Let me know if you have any questions. Thank you so much.